So quickly, let us review a little because this is for those who are not in the class, will be seeing the recording. So today we are discussing about the management of the chronic visceral pain. And visceral pain has a lot of atypicalities if you compare with somatic pain. So unlike somatic pain, visceral pain is diffuse and pathways project at the multiple levels. Proportion of fibers is lower compared to the somatic, and the pain response is limited compared to the polymodal somatic response, and somatosensory cortex is poor at differentiating the source of pain. I have already explained this part. Here, the localization of the pain is usually poor. So first, the characteristic of the visible pain is that it is diffuse and having visible localization. It is associated with the emotional and economic features as there are connections exists between these fibers, afferent fibers, as well as the fibers of the limbic system. In unreliable association with the pathology, sometimes there could be minimal tissue damage, which is giving more pain, and sometimes there could be convergence of fibers that is actually leading to a referred pain. For example, a cardiac pain going to the arm that might happen in the visceral pain. So, pain stimulus usually starts from the nerve endings or receptors in the wall of the organs like the intestine, heart, or any other abdominal organ, visceral organ, which actually can detect the stimulants such as distension, ischemia, inflammation, or other senses from that organs. Primary afferent fibers is mainly the receptive fibers in the form of the A delta and C, and the afferent fibers typically go alongside the sympathetic, basically to the sympathetic afferent, and in few rare cases it can go the vagal route, that is a parasympathetic. Now they enter to the spinal cord from dorsal route, and they usually relay in the lamina 1, 2, and 5, and with dorsal horn the visceral afferent often converge onto the some neurons and receive inputs from the somatic structures, and this is the cause of the referred pain. Now, there is a second order neuron which actually continue up and along the anterolateral spinothalamic tract to go to the ventral posteromedial posterolateral nucleus of the thalamus, and from there spinous travel via the spinoreticular and the spinomesencephalate tracts, influencing the reticular formation and periaqueductal gray matter, which is responsible for the pain modulation. And from the thalamus, the third order neurons project into the somatosensory cortex and also to the insula and anterior cingulate cortex, and which is actually linked for the emotional and the autonomic components of the pain. And ultimately, all are integrated and downward modulating pathways from the PAG also goes and sends signals to the spinal cord. Now, this slide we have already described that the organelles, these send the signals through the splanchnic nerves at the upper part, lumbar sympathetic nerves in the lower part, and below we have the nerves that is mainly the superior hypogastric plexus and inferior hypogastric plexus. Now we have the ganglion, that is the stellate ganglion, which is the cervicothoracic ganglia, which supplies the brain, meninges, eye, ear, tongue, pharynx, larynx, gland of the skin, head, and the neck and upper extremities. We have the thoracic sympathetic ganglia, supplying the mediastinum, esophagus, trachea, bronchi, pericardium, heart, thoracic aorta, pleural, lung, etc. So pain originating from conditions like a C lung, which is actually a little bit interior, and which is in the somatic pathway that can be actually blocked by blocking at the level of the thoracic sympathetic chain. We have the celiac plexus supplying the large area, which includes the most of the GI tract starting from the distal esophagus to the mid transverse colon. Also pain from the liver, adrenal, ureter, abdominal vessels, also from the pancreas that can be carried through the fibers of the celiac plexus. Then they continues along the splanchnic nerves to reach the sympathetic chain. Now coming to the lumbar ganglia, which actually supplies the skin, vessels of the legs, kidney, ureter, colon, and testis. We have the hypogastric plexus, which is supplying the descending and sigmoid colon, rectum, vaginal fundus, bladder, prostate, prostatic urethra, testis, seminal vesicle, ureters, and ovaries. So, pain from the pelvic organ can be blocked by the hypogastric plexus block. And lastly, we have a single ganglion, that is the ganglion impulse, that is actually supplying the perineum, distal rectum, anus, and the distal urethra, vulva, and distal third of the vagina. So if you see the location from top to bottom, from the cervicothoracic ganglia, there is the stellate ganglia, It is situated at the level of the C7 at the junction of the transverse process and the vertebral body of the spine. Whereas the thoracic ganglia is situated at the level of the by the side of the thoracic vertebra, usually at the junction of the anterior two-third and posterior one-third of the thoracic vertebra. Whereas celiac ganglion is situated anterior to the abdominal aorta. Hypogastric lumbar ganglion is situated, lumbar sympathetic ganglions are situated exactly at the anterolateral corner of the L2, L3 and L4 vertebra, whereas usually they are more close to the L2-3 disc. Usually the ganglion at the level of L2 is closer to the L2-3 disc, whereas the ganglion at the level of the L3 is also closer to the L3-3 disc, and the L4 is almost at the middle and the most inconsistent. If we go downwards, we have the hypogastric plexus, which is situated at the anterior portion of the lower part of the L5 vertebral body. The whole of the L5 S1 disc, as well as the and upper part of the S1 disc. Again, it's a large ganglia. It takes fibers from upper ganglions, celiac, aortic ganglions, and renal ganglions, and they continues down as the inferior hypogastric plexus, which remains within the pelvic organs, and at the end, just anterior to the sacrococcygeal junction, we are having a single ganglion where the both sides the celiac sympathetic chain joins, and that is the ganglion of impart. It supplies the perineum, distal rectum, anus, distal urethra, vulva, and distal third of the vagina. Pain originating from these areas, if they are sympathetically mediated, that can be blocked by the ganglion implant block. Hope things are clear. Now coming to the celiac plexus block. So what are the indications for the celiac plexus block? First of all, pain originating from upper abdominal cancers. For example, it could be a CA or a metastatic CA of the liver, because CA is less common. Metastatic CA to the liver is the more common, which can be possible by the CA stomach. There could be possible of the CA head of pancreas, or in any other areas. In these areas, if there is a pain originating, or even in the lower esophagus, that can be blocked with the help of the celiac plexus block, and it's a quite common block for the malignant patients. And a number of blocks are commonly done, and mostly neurolytic block works here. Can anyone tell why neurolytic block work? Why not radiofrequency? So my question to all. So why we
Diffuse,
prefer doing the
diffuse large plexus.
It is it is so it is a very large plexus of nerves.
yes. Problem is, even with the mostly what we use conventional radio frequency, that the lesion size is only 2 to 4 millimeter. Whereas if you use the cooled radio frequency, the lesion size will be larger, but it still remains up to maximum 4 to 5 times of the celiac plexus. That means around 10 millimeter or around 1 centimeter. But the ganglion is more than that. It's a much larger ganglion. So to block them, neurolytic can spread, and we can inject up to, when if you are giving from the posterior side, you can give up to 40 ml of neurolytic agent from 20 from each needle, 20 from each side. Whereas if you are going an anterior approach, like ultrasound guided approach, usually around 10 to 20 ml just anterior to the aorta at the close to the level of the celiac trunk is good enough for blocking this ganglion. But remember, it is more dependent on the diffusion of the, that means how much area the drug is covering. Plexus is large, so that the area covering is more, it gives a comparatively better result. Now, it can be done for a chronic condition. It is known as the chronic pancreatitis. So, some people say if there is chronic pancreatitis and I am doing the celiac plexus block, if the pancreatitis increases, will the patient will be able to understand the pain or pain is increasing? The answer is yes. Because even if you block it for the chronic pancreatitis, you cannot block 100%. Ultimately, it will increase the intensity of the pain. It will not completely block the pain, so that if there is exacerbation of the actual condition, the patient cannot understand. They will be definitely be understand, but the pain score and the pain intensity would be less for those patients. Now, usually it has been found that according to the Guyot's classification, falls into the current evidence growth falls into the 2B. Now coming to the structure. We have already told this part, but we have to see. So what is this? This is the greater splanchnic nerve, which is combined by the T5 to T9. Then we have the lesser splanchnic nerve, which is coming from the T11 and T9, T9 to T11. And T11, 12 is the least splanchnic nerve. In simple words, we remember like that T5 to T9 is the greater splanchnic, T10 to 11 is usually the least splanchnic, lesser splanchnic, and least splanchnic is T12. Definitely, one to level up and down is always there. Like that, they crosses and they goes by the side of the aorta. So basically, first they will be going by the side of this is T11 and T12, and then the crosses actually the cracks of the diaphragm. And after crossing the diaphragm, they come to the anterior side of the aorta, just around the celiac plate trunk, origin of the celiac trunk, they forms the ganglion. So if you want to block, either we can come here at bifurcation, or we can come just at the close to the aorta, close to the bifurcation. That both are good enough because there is a large ganglion and you have to give a large volume of the drug. And if you go below, you will be able to see the supramesenteric artery as well. And at this point, we can block for the celiac plexus. If you block here at this point, okay, so basically this is a splanchnic nerve block. So splanchnic nerve block is usually done at the level of the T11 and T12, whereas the celiac plexus block done is at the level of the L1 because it is going anterior as it goes below. So from the anterior side, we can see the ganglion like this. Now, either you can come from the anterior side, then usually one needle is good enough. If you put it here, it will cover this ganglion and this side as well. But if you are going for the posterior side, either you can take from this side or that side, or you can come piercing aorta. That is also a technique. It is known as the trans-aortic technique of the celiac plexus block, where we actually pierce the aorta and come to the anterior side and block there. Okay, and this is usually known as the trans-aortic technique. With the ultrasound, we usually cannot do the posterior block. We can go only from the anterior side block. It has some advantage, definitely. Like in ultrasounded celiac plexus block, actually, you can do the patient in the ward instead of OT. Only you should think the resuscitative equipment should be there and you can do in the ward itself, not taking the patient to the OT. And another big problem while doing this block in cancer patients is that sometimes there is presence of ascites. So it is very difficult and very painful for the patient to remain prone. Okay? So in that case, either you can go for side from the lateral position fluoroscopy guided approach, or you can go for the ultrasound guided approach, which is simpler and much easier doing from the anterior side. So we can block these areas and actually that can relieve the pain for the patient. Now, according to where you are putting the neurolytic, it is named differently. For example, if it is done at this point, that means anterior to the cracks of the diaphragm, so it is called the anticrural approach of the celiac plexus block. If it is done at the posterior part of it, it is usually known as the retrocrural celiac plexus block. If it is done above or by the side of the T11 and T12, it is known as the splanchnic nerve block. So terms differ, but you can understand we are targeting the same structure, either close to the its origin or little distal, just anterior to the outer. In that way, you can differentiate that from which area we are blocking according to the names there. Remember, while we are doing ultrasound guided approach, we are actually doing an anticrural approach. Okay? Anticrural anterior approach, and it usually pierces either the stomach or the liver. Initial understanding it may appear that we are in a normal patient, we are in a disease patient, we are puncturing the liver or puncturing the stomach. What could be the consequence? Stomach actually can do a peritonitis or there could be calm of infection, but usually we usually give the cover. This is the standard technique. If the coagulation profile is okay, even the puncturing the liver is not making any difficulty. But if you choose that which one is easier, puncturing the stomach or puncturing the liver, definitely puncturing the liver is comparatively easier because here the needle visualization is better because of the ecotexture, which is comparatively homogeneous compared to the ecotexture what you found when you are going to the liver because of the air and the other structures like food. So it is very difficult. So one thing is very important, the preparing the patient. Okay. So that you have to give a purgative before 1 day before so that the abdomen is clean and you can see the structures clearly, and we can perform the block better as well. It's very important. We're coming to the structures that we see while we are doing this block. So basically, what are the structures there? So from right side, if you go, we have the liver at the top, and then we have the portal vein, then we have the IVC, and then we have the aorta. So basically, we have target the aorta and IVC, which is actually anterior to the vertebral bodies. Okay, usually the L1 vertebral body. Now, the celiac trunk is coming up from there as the perpendicular structure. So, whenever we are following the aorta and perpendicularly you see blood gushing up from the aorta. And this, if we understand, this is the celiac trunk. Celiac trunk divides into its two branches. Okay, remember, if you read, you can remember there are three branches of the celiac trunk, and one is the left gastric artery, which supplies along the lesser curvature of the stomach. But this artery is a very small artery to look at such a depth. So actually, we can see divisions, one going to the liver, that is the common hepatic artery, and one going towards the spleen, that is the tortuous splenic artery. In the beginning, it is not tortuous, but as it continues, it actually goes over the pancreas as a tortuous artery. So here we can say it's a two artery division. One is the common hepatic, one is the splenic. Have to find out these divisions of the blood's gushing towards both the structures. One side it is the towards the liver and one side it is towards the spleen. So usually scanning starts from the VC sternum and we follow the out because blood vessels under ultrasound is comparatively easy to follow. Like this, we should check in the short axis view. And as we go down, we can see these structures. So what is this structure? Can anyone tell?
The vertebral body,
Yes.
anterior body.
Vertebral body. Actually, we cannot know. If when we are just putting, we cannot know which level it is, but it is definitely this hyperechoic structure is the vertebral body. Then we have two vessels. Okay? One this, one this. Usually, this is the aorta because of the left-right location, and this is the if we are holding the index marker towards the right side of the patient. So this becomes the liver, this becomes the stomach, this becomes the aorta, and this becomes the IVC. But definitely, you can check the pulsation clearly, and you're holding pattern to differentiate, as well as the echodection of the liver and stomach also helps that where you are actually holding the probe. So this is the IVC, liver, and this side is the aorta. So as we have found this structure, then we try to locate the gush of blood moving up like this. Okay. So this is an alternative way. Basically, this is a longitudinal scan where we can actually see the three different branches from the aorta. When we are holding a longitudinal view, we can see this structure. So if we draw, this is the aorta. From the aorta, this is on the longitudinal view, where the index marker is hold towards the head. So basically, this is the celiac trunk. Here we cannot see any more because it is dividing into perpendicular branches, so we cannot see any more here. But this artery, can anyone tell name of this artery that I am drawing now?
Superior
Superior
mesenteric artery.
Yes, perfect. This is the superior mesenteric artery. So in longitudinal view, we can see this picture. Now there are certain studies which have done this block from below upwards in the longitudinal view, putting the needle from here to here. But it is comparatively difficult actually, and sometimes I feel. Sometimes it is easy. In that case, you cannot go from the top definitely. Then you have to come from the below, and then celiac trunk comes into the way. But the advantage is that you don't have to be very accurate. Just one second. Hello, hi. Can everyone hear? Okay.
Yes.
Okay, fine, fine, fine. So I'm very sorry. So you check this area. So they comes like this. They comes like below. But that is not the standard technique. But yes, it is demonstrated in a few studies. So you have to come like this. At this point, you have to just inch it. Okay. But the classic technique, and which is more described, is the other way. It is the seagull view, where actually this spine, IVC and aorta is first located, and then the aorta is actually, we are searching over the aorta to the gush of blood moving above. We have to find out this gush of blood and dividing into left and right. It is easy to say, but even in, except for the low, this very, I should say, lean and thin patient, sometimes it is very difficult to get. And if the patient is not prepared, it is much more difficult because usually the transverse colon is again at the L2 level, and the transverse colon covers all the structures below. So that sometimes happens. Always do a bowel preparation before doing this, because otherwise it is very difficult. And this division, celiac trunk, sorry, aorta, celiac trunk, this is towards the common hepatic and this is the splenic. It looks like a flying seagull. So that is known as the seagull sign. And this is our target. Either we can go here. If and when you are seeing seagull, you can go slightly up and then see only the aorta and go in front of the aorta, close to the origin of the celiac trunk, or you can simply drug just above the seagull, and that is good enough. And if there should be adequate spread so that it covers the whole of the ganglion, so that it actually block this ganglion. Okay, so here you can see when you are giving color, it will look like this. Again, I am telling, when the patient is not prepared, it doesn't look so good. It is actually, then it is a little bit difficult to see. So that is how we should complete our block, and we should come out. And there are complications with this procedure as well, like bleeding, retroperitoneal hematoma. There are chances of the perforation, pneumothorax, chylothorax. There is possibility of the impotence, possibility of the paraplegia. There is possibility of the vascular injection, infection, thrombosis, embolism, and there are chances of the intrathecal and epidural injection, and it can cause hypotension and diarrhea. So remember, this is one of the common complications of the celiac plexus block, diarrhea and hypertension. For hypertension, usually we do a technique that is known as the preloading, and it is giving around 500 ml of ringal lactate just before doing the procedure. So that we can actually increase the volume and we can reduce this pressure drop. And regarding the diarrhea, sometimes it could be very difficult to manage. So what happens most of the patient? Usually the most of the patient of the cancer, they are dependent on the opioids. And when your patient is on opioids, then this opioid-induced constipation counteracts with the diarrhea, and usually it favors the patient instead of going to bad. In some patients, especially in chronic pancreatitis or even in cancer, sometimes it happens that even with the opioid, the diarrhea persists. In those cases, we can give the opioids, like and along with we can give atropine, and these sort of treatments can be helpful. Sometimes somatostatin analogs are also given. Now coming to the hypogastric plexus block, which is ultrasound guided hypogastric plexus block. Hypogastric plexus block, as I already told, it is a good block for the patients where the pain is originating from the bladder, urethra, uterus, the vagina, vulva, prostate, penis, testes, rectum, descending colon, perineum. So all these areas we can actually go for the, if they are sympathetic and immediate, we can go for the superior hypogastric plexus block. And it could be secondary pain because of the metastasis to the pelvis, like cervical cancer, prostatic cancer, testicular cancer, colorectal cancer, in case of endometriosis, or in case of the radiation related injury. And if it is causing chronic pelvic pain, we can put the block in the superior hypogastric plexus and we can give a relief. Now, in ultrasound, the target is, as I told, it is the anterior portion of the fifth lumbar vertebra. But before showing the exact target, let us show you this image because this is important. See how these structures are there. If we see, it is the anterior part of the L5. Basically, here the superior hypogastric plexus is. So we have to follow the bifurcation of the aorta. Now, once we got the bifurcation of the aorta into two common iliacs, we will get the union of veins as well. So the left common celiac vein is going towards the right celiac, and they are actually forming the IVC. So come a little below from that, and here it will look like a frog sign. That means in both the sides it will look like this, and this is known as the frog sign. Actually, in both the sides there will be vessel, and just below inside them we have to target. So we have to target here in both the sides there will be vessel, and here we have to inject approximately 10 to 20 ml of neurolytic agent, or you can go with the local anesthetic steroid if you're going for the diagnostic block, and then we have to come out. So here obviously you have to puncture the gut, but it is not dangerous. If you have done the bile preparation, you have given the cover, antibiotic cover to the patient. So you have to come to the anterior part of the fifth lumbar vertebrae, and then we have to give inject in front of the L5. Now complications includes the bleeding, especially into the retroperitoneal space, nerve injury, sometimes paralysis, puncture of the surrounding organs, puncture to the adjacent vessels, and that sometimes there could be possible distal ischemia. So that was in the theoretical part. So if you have any questions, no questions. So let's demonstrate. But remember, one thing is very important. Uh, I do not know whether we'll be able to see the celiac or not, because what happens in the evening time, the patients are mostly not well prepared, and that time usually stool is there. So if you are practicing, practice in early morning in the volunteer. In that way, the celiac plexus is seen better. As the evening comes, usually the stool accumulates and the vision picture is usually not that great. Okay. Let's see today what we see. We're able to see the structure or we'll see only stool. Okay, let's go to the other room and we'll start showing you the demonstration. First, I will demonstrate definitely what I can demonstrate reliably, that is the superior hypogastric plexus block, how to do it. And then I'll be trying to show you the celiac plexus if it is visible at this evening. Okay, so let's start. Hello. नहीं, नहीं, sir. Am I audible?
Yes,
Yes,
Hello.
sir.
Okay, fine.
yes,
Okay. So let us share. Can you see the volunteer as well as the ultrasound? So here we will be choosing this probe. আমি দেখ প্রোবটা দেখতে পাচ্ছি কোথায় না এইখানে কোথায় ক্যামেরা কোথায় ও দূরে ক্যামেরাটা কোথায় ওকে okay so we are using the curvilinear probe, okay, because as the structure in deep, usually curvilinear probe is preferred. This is the left side of the patient, this is the this is the right side of the patient, this is the left side of the patient, but this will be the right side of the patient, will be the left side of the screen, okay, as I am holding with this marker towards the left side like this, okay. So left side of the screen will show you the right side of the patient. So usually, to find out the superior hypogastric plexus, we start as a rough, you can take close to the umbilicus, okay? So umbilicus is not a fixed point, but in most of the case patient, it could be close to the umbilicus. So let us see and try to find out that whether we can get the aorta or not, okay? So it is quite deep. Can everyone see the aorta now? Let us take the pointer. So this is the, can everyone see this?
sir.
Yes, sir.
This is the aorta. Okay. If this is the aorta, Then with respiration, the picture is changing a little. This side, it is the IVC. Okay. So let us try to focus them a little more better, but definitely a lot of gas shadows are there. So aorta pulsation, you can see clearly. Here it is the IVC. It is also pulsating, but it's a venous pulsation. It is not that clear. And I am just drawing where it is the location of the vertebra. So this is definitely not the L1 vertebra because at the L1 it starts dividing. So it will be a vertebra which may be L3 or L4. So we have understood these structures and definitely these are the guard shadows and we have the skin and subcutaneous tissue there. Okay. So along with the respiration, it will be moving. So I think hope the structures are clear to you. So you just try to see with the movements of the respiration because with respiration, sometimes the structure is getting a little blurred. Sometimes it is going a little better. Okay. Everyone understood the structures here? Or I should explain once more? Say yes, no, anything.
Understood, sir.
Okay, fine. So now what we are doing, from this point, we are gradually coming down. Definitely in between you can see some gas shadows. So image is becoming obscured slightly, but still with that also we are going down. Okay. So this is the level of the L5, okay, not L1. We are trying to go close to the L5. Now I have gone a little below the umbilicus. Okay. And again, we are trying to find out. Now we can see instead of one, now we can see two vessels. So where are the two vessels? So here is the vertebral body. Okay. Here is one vessel and another vessel is this side. Okay. So here it is looking like a frog. So this is one vessel. This is another vessel. This is the vertebral body. Okay. Sometimes it could be a little more clear. Sometimes may not be that much clear. But at least you should identify the structures. Actually, our volunteer is not a very thin volunteer. So it is a little bit deep. So the structures are not very clear. But at least you don't have to understand much, but at least you understand the bony marking. And in both the sides, you can see the vessels. Okay, now we can see the two vessels, vein and artery both. Okay, so this picture is comparatively better. And we can see, and this is actually the classic frog view. Okay, so the arteries appeared as a eye of the frog, and the lumbar L5 lumbar vertebra appears as a head of the frog or mouth of the frog. Okay. Now, at this, when you are getting this view, in this view, we have to enter. If you are holding like this, and we have to enter from this side. Okay. Just try to see. This should be my needle if we are putting the needle like this. Okay. And ultimately, we'll be reaching. So we have to put the needle like this. Okay. So this could be our perfect needle trajectory. And remember, as I shown in the picture, every time the needle could not be that much clear because the angulation could be a very obtuse angle, but you have to go there and hit the vertebral body, come 1-2 millimeter back, and then inject 10 to 20 ml of the local anesthetic if you're doing the diagnostic block, or if you're doing the neurolytic block, either you use 6% phenol around 10 to 15 ml or 20 ml, or we can use the alcohol, which is around 70 to 90% and usually same volume as the phenol is given. Okay. So that is how we should complete the block and we should come out. And one thing is very important, after injecting alcohol, you should inject a little bit normal saline. And before injecting alcohol, we should inject the local anesthetic because alcohol is very burning agent. So it causes a burning sensation there. So before that, inject around 4 to 5 ml of lignocaine, then inject the alcohol and keep the alcohol concentration is comparatively higher side because it will be somehow diluted in the local anesthetic. So as told you, around 90% of alcohol or 70 to 90% of alcohol is usually good enough for this point. And here also, we cannot use the radio frequency because radio frequency is only covering a small area. It's a large area and we cannot actually cover with the radio frequency. Okay. So we have to go for the neurolytic block only. So I think this part is clear to you. Next, I'll be going for the search for the celiac, but you see, it's a quite heavy patient. So getting it sometimes may be difficult, but we'll be trying. So only ways you might get heavy patient, but do a good bile preparation. Then what will happen? The stool shadow from above the area will go, and in that case, you will be able to see much better. So here I am holding the probe at the level of the zipistala. Okay. And we have to find out the structures, what we can see below. Okay. Again, it's quite deep. In the pockets. Hydrate down. Okay. So I've told you, you will be getting some shadows. So we are getting a big shadow of the colon. It is coming from this side. So I will try to handle it so that we can get a window for the vertebral body. Vertebral body seems here at such a deep area. Okay, this arrow, close to that arrow, we have the vertebral body. So in some patients, giving a little pressure helps. This side we have the stomach and this side we have the liver, and above all, we are having the colon. So let's try here all the colon shadows we can see. Okay. At this point, again, we are seeing the vertebra. So let's see, and this is the aorta, this is the IVC. Wow, everything is cloudy. Okay, so see, what we can see here is basically this is the aorta. But again, there is a large stool which is casting a big shadow here. So in between, we are getting a small window. Let us try to focus to that small window if you can see the other vessels. So now we are getting a few bit of the superior mesenteric artery just coming out from this shadow. Try to see close to this shadow. We are getting a vessel which is going above. It is usually the superior mesenteric artery. But still we are having a big shadow in front of the celiac. Okay. Now trying with the cross section. Okay, so I'm just showing you the points because all are hidden behind the colon here for this patient. So we have a good video that I will share to you because there will be able to see the clear bifurcation. Right now, what I am showing that what you have to go, how we have to go. So first, hold it at the Zipisternum, come down and try to look at, see, even if you are missing the celiac trunk, you will be always be able to see the aorta. And we have to find the aorta in those patients. Okay. So here we are getting the aorta. Okay. So this is the aortic shadow, aortic movement, what we can see. And this is the vertebra, L1 vertebra. L1 we cannot say because as long as we are not seeing the celiac trunk, we cannot exactly comment it as L1. Yeah. And what you have to do, I'm just telling you what are the steps basically. So at this point, you will see some gush of blood. Okay, it is starting, I think. We are very close. You see carefully, a little blood is moving from this direction. Okay. Can you look at this upward movement of the blood from the aorta? Let's give color. Not easy. I'm saying it is difficult. Okay, now see, you see upward movement of the color. See, this is the gush of the blood which is moving from the aorta. I'm just focusing that part. This is the gush of the blood which is moving from the aorta and then going towards this is this portion. This portion is the common hepatic and another portion will be moving to this side. Definitely with the respiration, it will be moving. There are a lot of shadows, but at least let us stop in a place where we can actually. Okay. So now I think you can see. So it is definitely not seen very beautifully, but this is the aorta portion. Okay. From the aorta, this is the gush of blood moving up. This is the celiac trunk. This is the common hepatic, and this side also, it is not focused properly, but this side also there will be another vessel, and this is actually the Seagull's sign at this point. Okay, so it is the splenic artery, the splenic, common hepatic. This is the celiac trunk, and here we can see the aorta itself. Okay, and this is the vertebral body. So we have to take the needle from left to right or right to left. So either puncturing the to which side হয়ে গেল? Not it. Okay, so we have to come like this. Okay, so either here or we can go a little proximal and then we can come close to the aorta as well. Okay, so even with this lot of shadows, gas shadows and everything, we are able to look at the celiac trunk. That's a good thing, but it is always advisable to prepare the patient. Okay, then only we'll be seeing a better picture. Otherwise, seeing the better picture, you cannot see. And while practicing, you cannot give purgative to volunteers. So what you can do, you try at the morning. Okay, take a volunteer, take your ultrasound probe, practice in the morning time so that you can get a better picture of this time because when the stool is empty. Okay, that was all about these two blocks. Any question you have? Okay, no questions. Then let us say goodbye for today. And but I think it will be better if we do some questions to you because whether you have understood properly or not, that will be clear. In celiac, I don't think it is better, but at least for the superior hypogastric, the structures are quite visible. So let us focus and let us ask you whether you are able to find out the structures or not. Okay, so we have started the scanning and I will stop at any moment. Okay, again, I'll hold the probe in the same way. That means this side is the right side of the patient, this side is the left side of the patient, and the screen, the right side is at the left side of the screen. Okay, let us hold it there. Again, a lot of gas shadows and other things are there, but most of the structures are visible. Not very good. Let us take a better picture whether we can get or not. Yes, this is better. But another structure is seen just below the arteries. Draw that as well. Okay. Change करो ना. ठीक है. So what is this structure? First structure, yellow colored structure. What is this?
Vertebral body.
Vertebral body.
Okay, the red colored vessel. What is that?
The vein.
Yes, which vein?
By the bifurcation of common iliac vein.
Yes, basically it is the left common iliac vein, which is actually going towards the right side. So that is why you can see that. Okay, and by the sides, this is one, this is another. So what are those?
The arteries, the bifurcation of the common iliac arteries.
No, these are not common iliac, these are veins, because here you see, here we have this is the hypoechoic structure. This is basically the vein. Vein from the left side coming towards the right side to join with the other one. And these are the arteries. As I have put pressure, the venous part is actually blenched here. Okay, you cannot see much of the vein except for that part where the pressure is less. Okay, so let us try to show the artery a little better. Okay. Let's try whether we can get a better picture. So this is one. Here it is not divided. Here you can see the artery and vein. Okay. Here it is a little above. It is not divided. But as we are going down, no, it is not a good today. Okay. And the volunteer, we cannot see much better today. I have shown you the best views possible here, but definitely you practice in the volunteer, you will see them much better if the patient is lean and thin. Though even in thick volunteer, if you see this picture, this is good enough. It is very simple. See the bifurcation, go to the top, and you can just put the drug. So it will be easy enough. Okay. I'm not asking questions now because the image is not that quality that I can ask you questions. Okay. So next we have the part evaluation. So we will be giving the part evaluation, and one batch there will be the final evaluation. We will be giving the final evaluation as well. So let's say bye-bye today. Good night.